In this video, we will talk about the pharmacology of gout disease. It is a disease caused due to ineffective purine metabolism that leads to increased level of uric acid in our body. Either the uric acid is produced in excess or its excretion from the body is decreased. Basically, it's an intermittent attack of acute arthritis caused by deposition of urate crystals in our body. It's synonymous with hyperuricemia. It can be primary or secondary. Primary gout is due to unknown reasons or any genetic enzymes defect. Secondary gout have an association with cancer therapy, cell and DNA degradation, overuse of drugs like loop diuretics, levodopa, etc. Now we will discuss the drugs' use in treatment of gout. First come the acute management of gout that include three main classes of drugs: NSAIDs, colchicine, and glucocorticoids. NSAIDs are used as initial therapy for acute attack. It includes indomethacin, naproxen, diclofenac. Diclofenac reaches high concentration in synovial fluid. These are better tolerated as compared to colchicine. Now colchicine is neither analgesic nor uricosuric. It binds to tubulin, and decreased microtubular functioning leads to decreased leukocytosis and phagocytosis, thus decreased inflammation. As it's antimitotic, it is also used as anti-cancer drug. Adverse effects of acute use of colchicine is severe GI disturbance, and its chronic use leads to hematuria, myopathy, neuropathy, and alopecia. Now come glucocorticoids. When gout does not respond to NSAIDs and colchicine, we use glucocorticoids. It includes prednisolone and methylprednisolone. It can be used systemically. If one joint is affected, then intra-articular injection of glucocorticoids are given to avoid side effects. Now we will discuss the drugs used in chronic management and prophylaxis of gout. Firstly, uricosuric agents inhibits the active tubular reabsorption of uric acid in proximal convoluted tubule, so it increases the excretion of uric acid from the body. It includes probenecid and sulfapyrazone. It is poorly tolerated, so it is advised to be given with increased fluid to prevent the urate crystals in the body. Its contraindication include that it is not given in the patient of renal failure, because probenecid is ineffective when GFR is very low. It interacts with various drugs listed here, so it increases its half-life and effectiveness. It is not given in the acute attack because it will worsen and increase the frequency of the gout. Now come the uric acid synthesis inhibitors. It inhibits xanthine oxidase enzyme, thus hyperxanthine is increased, causing kidney stones. Allopurinol comes under this class of drugs. It is a substrate for xanthine oxidase. It decreases the urate crystals, thus used in asymptomatic or chronic gout and hyperuricemia due to cancer therapy. It is not given within 3 weeks of acute attack. Its adverse effect includes hypersensitivity reaction, Stevens-Johnson syndrome, severe nausea, vomiting, and diarrhea and hepatotoxicity. It interacts with 6-markup-topurine that is inactivated by xanthine oxidase enzyme, but activated by alloxanthine. It increases its effect, decrease the dose requirement, and decrease the side effects. Second is febuxostat that is hepatotoxic. Third is racbaricase that oxidize uric acid to allantoin. Its side effect is hypersensitivity reaction.